We are live now, ma'am.
Yes.
Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar HTP, organized by Pinnacle News Series Episode-6 in association with Jammu, Bardhaman, Dibrugarh, Hisar, Bijapur, and Gulbarga OBGYN societies. It's my privilege to introduce the MOC of today's webinar, Dr. Madhumita Arun Karthik ma'am. Ma'am is the treasurer of Salem chapter of Tapisar, EC member of OGSOS. I welcome you, ma'am, and I hand over the session to you.
Madhumita?
Thank you so much. Yes, thank you so much, Sahiti, for the kind introduction. Now we'll move on to introducing Sampath ma'am.
Prayer, yeah.
Yes. This webinar series, that is Pinnacle News, covering the all parts of India, is brought to us by Professor Dr. Sampath Kumari ma'am, who's the Foxy Vice President 2022. She's a Senate member of Tamil Nadu Dr. MGR Medical University, National Corresponding Editor of Jogi, Founder Secretary Tamil Nadu Federation of Obstetric and Gynecology, and retired Deputy Director, Institute of Obstetric and Gynecology, Chennai. And President Board of Studies of Tamil Nadu Dr. MGR Medical University. She was a past chairperson of Foxy Adolescent Health Committee, first ICOG Distinguished Governing Council Member Award, and she's also the chairperson Women's Wing of IMA Chennai and IMA National President's Award and IMA Tamil Nadu Stage Branch Award she has received. So next, moving on to the prayer song and the lighting of the lamp. Now for the welcome address by Sampath Kumari ma'am.
Good evening to all. This is the Pinnacle News Series. The news being N from North, E from East, W from West, and S from South. We have societies from throughout India, from all North, East, West, and South. This is the Pinnacle Series number 6. Today we are covering the hypertensive disorder in pregnancy. The societies today included are Jammu, Dibrugarh, and Bardhaman, Hisar, Bijapur, and Gulbarga. And I welcome Dr. Rati Sharma and Dr. Mandusha being the President and Secretary of Jammu Society, and Dr. Pranay and Dr. Jasmina from Dibrugarh Society, President and Secretary. And I welcome Dr. Rabindranath and Dr. Shankar being the Bardhaman Society, President and Secretary. And I welcome Dr. Gurneet Singh and Dr. Kritika, Hisar Society, President and Secretary. And Dr. Shailaja and Dr. Shobja, the President and Secretary of Bijapur Society, and Dr. Hema and Dr. Usha being the President and Secretary of Dr. Gulbarga Society. Now we have the wonderful talk by the Dr. Meeta on Gestosis score. And we have our chief guest, Dr. Vidya Topi, who is the Vice President-elect. And we have the guest of honor, Dr. Pranay, Dr. Rati Sharma, and Dr. Gurneet Singh. Then finally, we have the panel discussion. about the HPP complications. Now I welcome Vidya to be joined Panyacha. So otherwise we will go with Dr. Gurnesh Singh is there. Dr. Gurnesh Singh is the guest of honor and he is the president of Hisar Society, former professor and HOD of the Obstetrics and Gynae, Maharaja Agrasen Medical College, Agroha. His professional experience, more than 24 papers published, and he contributed various chapters in Foxy publications. Clinical experiences is still continuing. He has many honors and awards to his credit. And professional affiliation is member of Urogeny and Pelvic Floor Committee Foxy and vice chairperson of Embryology Committee Hisar, Haryana, IFS, SOSI, and IMA. His area of interest is urogynecology, ART, endoscopy, and high-risk pregnancy. Dr. Gurnesh, we wish you to bless the program. Dr. Gurnesh, 2 words.
Thank you, Dr. Sampat. Madam, it's so nice that you have made me part of this webinar series. It is a very important topic, almost affecting 10 to 15% of all the ladies which we see in our OPD. And though with the treatment, the incidence of eclampsia has come down, but still it is a topic which very much affects the ladies, especially in the Hisar area, which is a very rural area, and a lot of neglected pregnancies still come, a lot of eclampsia cases still come. So I hope this webinar will go a long way in clearing many doubts and everything. So in the end, thanks for suggesting such a nice topic, ma'am.
Thank you, sir. Thank you, Gurnesh, sir. If time permits, be there. Next, Dr. R.C. Sharma is there. R.C. Sharma, sir. And Dr. Pranay. Yes, whenever they join, we will get the blessings, Madhumita.
Yes,
And welcome the MOC, Dr. Madhumita, to introduce the chairpersons and the chairpersons to introduce the speaker. Welcome. Yes, Madhumita.
So moving on to the first session, we have a very interesting and informative talk by Dr. Meeta Gupta. And to chair the session, I invite Dr. Shailaja Bidari. Ma'am is a professor in HOD at Department of Obstetrics and Gynecology at Vijaypura in Karnataka. And she's also the Executive Council member of KASOGA. And she has numerous publications to her credit, and she has various international research projects also. And she's also the current president of Bijapur Obstetric and Gynecological Society and executive council member of Karnataka State Obstetric and Gynecological Society. The next chairperson, I invite Dr. Usha Doddamani, who's a professor and HOD of Gulbarga Institute of Medical Sciences. And she's also the present secretary of Gulbarga Society. And she's also the comprehensive abortion care coordinator for Gulbarga and the master trainer for BMONC. Welcome you, ma'am. I request you to please introduce our speaker.
Good afternoon. It is a pleasure to introduce the eminent speaker of Gestosis, Dr. Meeta Gupta, MS FICOG. She is a Dean of Academics, Professor and HOD of Obstetrics and Gynecology, AIMS Vijaypura, Jammu and Kashmir, winner of Women's Health Researcher Award Senior Category, Advanced Course in Medical Education, teacher of the last 18 years with a special interest in adolescent health and high-risk pregnancies, many publications to her credit. Welcome you. Over to you, madam. It is.
Thank you so much, ma'am. Shelja ma'am, for introducing me.
Thank you.
And thank you, Sampat ma'am, for giving me the opportunity to talk on a topic that is very close to me. And that is the Gestosis score. Ma'am, is my screen visible?
Go to the slideshow, Meeta.
Yeah, ma'am, is it there?
Yes, ma'am.
Yes,
1 point, Meeta, because Meeta was doing this Gestosis score first in India. So she has presented in one of the Gestosis conference. That's the reason I thought she should present in our series, such that everyone can understand what is Gestosis score and how it's to be done. Yes, Meeta.
Thank you so much, ma'am. So I'll be talking about Gestosis score. That is very, the most important part is that it was developed by us Indians, one of the few people who have been working very hard in the prevention of preeclampsia and eclampsia in India. And how can this score be used to predict and prevent eclampsia later in the pregnancy? So greetings from AIMS Jammu, from top of India, that is the J&K state. So we all know that the HTP spectrum, it ranges from very mild diseases in which the patient may have elevated blood pressure with very mild clinical symptoms, or to the other extreme where the patient may present with severe hypertension and multi-organ dysfunction, maybe end organ damage. Looking at the burden of the disease, as Sir has said, that worldwide the incidence is about 5 to 8% of all pregnant women. And in the developing countries, it ranges from 1.8 to 16.7%. And as an Indian study, the overall pooled prevalence of preeclampsia in India is about 11%. If we look at the National Eclampsia Registry of 2013 that the FOXI had started, the incidence is about 1 in every 10 pregnant women suffer from hypertensive disorders of India. This, we all know that the incidence of preeclampsia is increasing, and as a result, the maternal mortality attributed to eclampsia is about 4 to 6% according to this national registry. So, to control the maternal mortality, we have to take care of preeclampsia and eclampsia patients. It is without doubt that the incidence of preeclampsia is increasing, and it could be attributed to the lifestyle modification, which include increased weight gain during pregnancy or obesity, prevalence of gestational diabetes, advanced maternal age, and of course, increased prevalence of cardiometabolic diseases in women of the childbearing ages. Why we are talking for preeclampsia is because it is associated with major complications both in mother and fetus, and it can be deadly for both. In the mothers, it can present with abruptio placentae, DIC, pulmonary edema, acute renal failure, cardiac rhythm disorders, and end organ damage, all causing to maternal mortality and morbidity. Whereas in the fetus, it may present with initial stages as fetal growth retardation, leading to preterm deliveries, and sometimes in uncontrolled hypertensive mothers, it can lead to fetal deaths. If we look at the FIGO guidelines, they also say that prediction and prevention of preeclampsia is foremost, and for which they have set the biomarker use in which has to be done at 11 to 13 weeks of gestation, which will include mean gestational pressure, PLGF, uterine artery pulsatile index, and PAP scores. So we all without doubt know. Please, you will have to excuse me because I'm having a very bad viral. So we all know that prediction and prevention would ultimately bring down disease of preeclampsia. Yes, ma'am. So if we can predict, we will be able to prevent and ultimately decrease the incidence of preeclampsia. So without doubt, early diagnosis is essential in prevention and prediction of preeclampsia. So universal screening has to be recommended. But the tragedy is that there is no single effective screening test available which can be used by one and all. And this is especially important because at present, whatever the screening tests are available are either invasive or ultrasound guided, which can be only done by a physician or a medical officers. And none of these can be advised or administered at the grassroots level of healthcare workers, especially in the rural population. And it is foremost important in India because majority of our females are in the rural population. So can we offer anything to all these grassroots level workers so that they can predict and prevent preeclampsia? And the answer is yes. This is a simple risk model named HTP Gestosis Score, which was devised by Dr. Gorak Mudrukar. It was further modified by a committee including Sanjay Gupta sir, Suchitra Pandit ma'am, Dr. Alpesh Gandhi and Dr. Girja Wagh. And this was used for effective screening of preeclampsia. It has further been endorsed by the Federation of Obs and Gynae. So what is important to understand that a careful history, especially in early trimester, can predict all these mothers at risk And this can be done by any health care worker by using the HDP gestosis score. Its advantages are that it is nearly free. It is freely downloaded from the Play Store in any Android phones. It is cost effective as we can screen all the antenatal patients early in the first trimester. It is very simple to use. It is mostly history based, and it requires additional measures like blood pressure, thyroid status, sugar status. That is all included in the antenatal protocol of each woman. And it can be the best advantage. It can be done at the very first visit of the antenatal mothers. So a gestosis score takes 27 items. The first to 14 items are usually associated with mild symptoms of preeclampsia, and each is given a score of 1. The second set of symptoms, that is 15 to 20, are usually associated with moderate PIH symptoms, and they are each given a score of 2. And finally, the 21 to 27 items are usually signify a severe PIH symptom, and each of these are given a score of 3. If we add each of the items, and if the score is more than or equal to 3, the pregnant female is said to be at risk of preeclampsia. So, what are the mild risk factors which each has a score of 1? Age, maternal anemia, BMI more than 30, a primary gravida, a short early marriage, or a short duration of cohabitation, that is within 6 months of marriage if the patient conceives, and a mother herself has a history of small for gestation or any family history of cardiovascular disease. A known patient of PCOS, if the inter-pregnancy interval is more than 7, if the patient has conceived with assisted reproduction, the mean arterial pressure is more than 85, or there is a history of chronic vascular disease or excessive weight gain in pregnancy. These are all the mild risk factors, and each has given a score of 1. Coming to the moderate risk factor, in which each would be given a score of 2, that is maternal hypothyroidism. If there is a family history of preeclampsia, patient is having gestational diabetes mellitus, if the BMI of the patient is more than 35, if there is a multiple pregnancy, or the patient has had a hypertensive disorder in previous pregnancy. These 5 are all given a score of 2 each. If there are severe risk factors like patient is known pre-gestational diabetes before the start of pregnancy, patient is a known chronic hypertension, she has any mental disorder, any inherited or acquired thrombophilias, maternal chronic kidney disease, autoimmune diseases, or if assisted reproductive technique, especially surrogacy or donor sperm and donor eggs have been used. These are all the risk factors that has to be asked by the patient. I had the honor of publishing the first prospective study to determine preeclampsia by the gestosis score in Jogi. This study was taken to assess the sensitivity and specificity to predict preeclampsia based on the gestosis score in the first trimester. It was a prospective cohort study done in hospital setting, and about 473 pregnant females were done, especially during the COVID time, that was October 2020 till October 21. Only the first trimester pregnant females were enrolled. We had excluded any patient who was already on antihypertensive treatment, any patient who came to be COVID positive, any known malignancy or liver diseases, or any history of intake of alcohol or substance abuse or alcoholic. We followed these patients and we measured whether they did develop preeclampsia or eclampsia. So, after the ethical clearance, written consent by taken from all the enrolled patients, a detailed demographic history, especially age, gravida parity, obstetrical history, menstrual history, PCOS, and whatever the risk factors was asked according to gestosis score was taken. Blood tests like thyroid, blood sugar levels, and blood grouping was done. We especially carefully checked the blood pressure and calculated the mean arterial pressure. And by the Gestosis app score, we calculated their scoring. And if the patient was more than 3, then they were diagnosed to be at risk of having preeclampsia. So this is what is important, that any women who had a score of more than or equal to 3, they were marked to be having at risk of developing preeclampsia later in the pregnancy. So out of the total 534 patients that we had enrolled, 473 were finally included in the study, as 47 developed COVID-19. There were few patients, about 10, who were lost to follow-up, and 4 did not give consent to be enrolled in the study. If we look at the gestational score, we realize that the females who had Gestosis score of 1 were about 200. The females in blue, that is, had a Gestosis score of 2, that is 204 of the patients, and only about 69 patients had a score of more than 3. So these were the patients who was at risk of developing, and they required a strict surveillance. So out of the 473 patients, only 71 developed preeclampsia, and in these 71, 59 patients were who had Gestosis score of more than 3 in the first trimester. In the remaining 12 patients who developed preeclampsia, only 8 patients had Gestosis score of 2, and 4 patients had Gestosis score of 1. This, even though it looks a very difficult chart to understand, but if you look at just the first, in which we are looking at the variables, and the last, that is the diagnostic accuracy, if we took a Gestosis score of more than 3, the diagnostic accuracy of this score was 95%. If we look at the Gestosis score of more than 2, then the diagnostic accuracy of this score fell to about 55%. So ultimately, the score of more than or equal to 3 was a better indicator for diagnosis preeclampsia. So HDP Gestosis score more than 2 was associated with higher sensitivity, that is 94%, but the specificity fell by up to approximately 49%, whereas a Gestosis score of more than 3 was associated with a sensitivity of 83%, but a very high specificity of 97% in predicting preeclampsia. So we all understand that HDP Gestosis score is more than 3 is a better predictor for development of preeclampsia. So now that we have predicted, what are the preventive strategies we can have taken? So early diagnosis and timely interventions is required to prevent preeclampsia, and this will help to reduce the financial burden to achieve the national goal of health for all by 2030. The preventive strategies would be the age of, if the patients are asked to conceive early in their age group, oral calcium supplements, folic acid supplement, an ideal BMI maintenance, pre-existing disease to be better cared for, and aspirin. Age is the most important detriment. So we have to advise women, especially coming in preconceptional counseling, to avoid extremes of age for pregnancy. Oral calcium is one of the best strategies to avoid preeclampsia. Anybody who is having a Gestosis score of more than 3 has to be given 1,000 milligram of calcium. And this is said to be one of the most effective mechanisms to prevent preeclampsia. The proposed mechanism is that once a patient has hypocalcemia, this stimulates the parathyroid hormone, and this in turn causes increased intracellular calcium in the smooth muscles, resulting in vasoconstriction, as a result causing hypertension. So calcium supplementation is a must. So it reduces the parathyroid release as well as reduces the uterine smooth muscle contractility. So improves the uteroplacental blood flow and prevents preterm delivery as well as preeclampsia. Ideal BMI maintenance during pregnancy is one of the foremost preventive strategies. If we look, coming to the low dose aspirin protocol, if we look at all the recommendations that have been given by various societies, be it ACOG, the US preventive strategy, the NICE guidelines, ISSHP or FIGO, all of them say that low dose aspirin has to be initiated. And usually it has to be started beyond 12 weeks. The dose may vary, but ultimately ecosprin, low dose aspirin is one of the best medicines to be used in prevention of preeclampsia. So the take home message is HTP is one of the most common medical disorders in pregnancy, and it affects both the mother and baby. HTP can be predicted with the use of HTP gestosis score, and once it is diagnosed, proper and regular antenatal visits are required to detect this preeclampsia. Use of gestosis app can be done by each and everybody, especially at the grassroots levels. It is available at no added cost. It is a free app which can be downloaded from the Play Store by everybody. You can identify the risk factor pregnancies in the very initial days or the first antenatal visit. As a result, every clinician can plan and provide systemic care to the patients who have been diagnosed as being high risk. Thus, we can prevent preeclampsia and all the other complications if we all follow a certain standardized clinical management protocols. So, it is my humble request for everybody that if we go step by step by use of gestosis score and regular blood pressure monitoring, we can prevent any mother from suffering and dying and can have a better or the best maternal and fetal outcome for each antenatal mother. Thank you, ma'am.
Yes, Doctor.
Thank you, Doctor.
Dr. Usha is there, I think. Dr. Usha can conclude.
Yes, ma'am. Yes, ma'am. Myself, Dr. Usha, ma'am, from Gulbarga. Thank you, Meeta, ma'am. It was a very elaborate talk on the justice score. So it is very useful tool so that even the grassroots level, the workers can use this app and they can try to identify the preeclampsia cases at the earliest so that we can identify them and prevent the development of the preeclampsia. A very useful score, ma'am, because the biochemical markers and the ultrasound Doppler that are being used at 11 to 13 weeks of gestation. So they are quite costly and are not cost effective. And sometimes even the Doppler, that is that at 11 to 13 weeks of gestation, cannot be used at the taluka level or at the PHC level. So I feel that gestosis score plays a very important role in the identifying the patients with preeclampsia. Thank you, ma'am.
Thank you, Dr.
Vidya Tobi
Usha.
ma'am has
Thank you so much, ma'am.
Thank you, ma'am. Thank you. It was
Meeta,
nice.
it was wonderful.
Thank you, ma'am. Thank you, ma'am.
If anyone is having the doubt, you can post in the chat box. Dr. Meeta will answer from the chat box. Okay. Now,
Vidya Tobi ma'am has joined, I think.
yes, now we welcome our chief guest, Dr. Vidya Topi. Dr. Vidya Topi is the president of Kasoga 2023 and state advisory PCP and board Karnataka, chairperson of Food and Drug Committee from 2018 to 20, and she got the Best Committee Award. And ICOG Governing Council member from 23 to 25, Foxy Champion Award 2019. She is a national corresponding editor of Joki, organizing chairperson of Kasoga, president of Bijapur Society 2009, secretary 2007. And she has more publications to her credits and presented many papers in national and international conferences, organized various CMEs. And she is traveling from Bijapur to Bangalore, Bangalore to throughout India. She is the incoming Vice President Foxy. So next year she has to travel a lot. And I welcome Dr. Vidya Topi, the chief guest, for to bless our webinar and wishes.
Yes. Thank you, my dear Dr. Sampath Kumari. I always admire her work as an adolescent committee chair as well as when she was vice president. Tamil Nadu is very dear to us, and she has, and now I congratulate her for becoming TNFOG president as well.
No,
And I
Oxy
look-
president. Oxy.
Okay, Oxy president, and maybe in future TNFOG president also. That is a step ladder, I suppose. She is doing wonderful work as a secretary TNFOG, and I attended one of her exclusive conference. This focused on hypertensive disorders in pregnancy, and she always does that. And she's a best teacher also. And I remember her visit to Bijapur as an adolescent committee chair, and she was so enthusiastic that she walked from our Jai Shri Talkies
Acha.
to our Kangal Hanumantraya temple. So she was one of the adolescent girl only that day. So she addressed our gathering, and it was the most memorable day of my life that she traveled a lot from her place to here. So I congratulate her. I'm looking forward for her future endeavors. I wish her all the best. I appeal for those societies who have joined to increase their capabilities, and please vote for a capable person who can be a leader. So our those from the North societies, those who have joined, they have also seen Dr. Sampath's so much extensive work. So from Jammu, I always meet Dr. Meeta across the webinars also, and I meet her during our conference, and I appreciate her work also. So congratulate again, and I'll be there for the panel also. So thank you very much, Sampath, for calling me as a chief guest. Actually, many times I'm a part of your this one. So I'm not a chief guest actually. So thank you very much.
No,
Thank
yeah, now you are a vice president elect. You are the chief.
you. Thank you. Thank you.
But still you are the chief guest. And now
Thank
you
you
are
very
expert
much.
in panel also.
Yeah,
Thank
yeah.
you very
Thank
much
you.
for your wishes. I
Yeah,
think
yeah.
Dr. R.C. Sharma and Dr. Pranay is not there. Are they, Madhumita, irukangla?
Dr.
Sir,
Pranay,
sir.
I have joined. Dr. Pranay.
And Dr. Pranay sir is there. Yes, sir. Welcome, sir.
Yeah, yeah.
Avroda CV
Yes,
podu Sakiti. Welcome, sir. Dr. Pranay, sir.
Just a
Yes.
second.
One
ma'am.
of our guest of honor. CV poduma.
Yes, yeah.
Dr. Pranay Pukan is the professor of Assam Medical College, Dibrugarh, and teacher of UG and PG and University Examiner, ICOG visiting professor 2015 to 16, AO for Young Gynecologist Awardee 2002, and President of Dibrugarh Society since 2022, and President ISOBAB Dibrugarh 2023 from 2023, and the publications of more than 30 original papers in national and international journals. His special field of interest is infertility and endometriosis. I think this is the endometriosis awareness month, no, sir? Trained in Boston, USA, infertility, contributors to chapters in postgraduate books in gynecology and pediatrics, and the chief editor of Handbook of Infertility for Practitioners, organizing secretary and chairpersons for OG conferences, and resource person in radio and television program on health awareness. Dr. Pranay, sir, welcome, sir. We wish that a seminar and bless us for this success of the webinar. Yes, sir.
Thank you, Dr. Sampath Kumari, for introducing me. It's really a great honor to be associated with you people. And I know your name for a long time. So when you approached me, I actually did not refuse it. It's really a great job that you are doing there, the south part of the country. And then as from eastern part, probably I am the only person, northeast part. I'm the northeast most parts of the country in the Assam, Dibrugarh. And I hope that all of you sometimes visit. We are also organizing one presidential conference in the month of September in 2025. I will invite you, all the people here.
Yes, sir.
It's a good thing. And then this topic that you have selected, definitely we might be dealing with so many infertility, endometriosis, so and so, robotic surgery and all. But HDP is still one of the most important, clinical conditions that killing a lot of murder in our country. So definitely we have to take care of that. One thing I want to say, the new generation of gynecologists, what I feel when I ask them, my students, what do you want to do? They want to go for reproductive biology, genetics, fetal medicine, then oncology. But very few people, they want to go for high risk pregnancy. And that the new trend that is coming, probably we cannot deny them. But at the same time, I hope that our new generation people will be attracted to this kind of basic thing that we are killing a lot of murder in the country. With these few words, I wish you all the best, and then I will be participating time to time. Thank you, Dr. Sampath, and everybody present here. Thank you very much. Yes.
Thank you so much, sir. Thank you, sir. If Dr. R.C. Sharma is there? Thank you, sir. If he is not there, we will go with the panel. Dr. Madhumita, you can introduce the panelists and our
Yes, ma'am.
expert.
Yes. So we have a very informative panel next on complications of hypertensive diseases in pregnancy and its management. So for the moderation of the panel, it is our Sampath Kumari ma'am. As we've already introduced ma'am, and she
Yes,
needs no
go.
introduction. I would move on to I would move on to introduce the expert, who's with Vidya Tobi ma'am, who is the president-elect of FOXY. Next, moving on to our panelists. We have Dr. Manjusha Bajaj, who's the secretary, Jammu Obstetric and Gynecological Society. We have Dr. Shailaja Bidri ma'am, who is the professor and HOD, and she's also the president of Bijapur Obstetric and Gynecological Society. Next, we have Dr. Shobha Shiragur ma'am, who is the professor and HOD at Vijaypur, and she's also the presently she's the secretary of Bijapur Obstetric and Gynecological Society. Next, we have Dr. Jivika Gupta, who is currently working as a consultant in Gobind Nursing Home. And next, we have Dr. Jasmina, who's the secretary of Dibrugarh Obstetric and Gynecological Society. Yes. Sati, can you share the slides, please?
Oh, I will share, no problem. 1 minute.
So give me 1 minute, ma'am.
No, Chanti, I will share.
Okay.
Can you see?
Yes, ma'am.
Yes, ma'am.
Yes. We will go with that. So I welcome you all for this. Vidya Tobi, you are expert, be there. So now I welcome the
I'm
panelists.
there.
Yes, yes, sir. That Dr. Manjusha, Dr. Shobha, and Dr. Jivika, and Dr. Jasmina, and Dr. Shailaja. Today our topic is with hypertensive disorder in pregnancy complications. So I moderate this panel with my co-moderator, Dr. Madhumita. See, as all of us know, the hypertensive disorder in pregnancy is classified as gestational hypertension, pre-eclampsia, eclampsia, and chronic hypertension. You had a wonderful talk by Dr. Meeta. So when the hypertension, that is BP is increased after 20 weeks without proteinuria, only BP is increased means we consider as gestational hypertension. If at all proteinuria is also present, we consider it as pre-eclampsia. Again, the pre-eclampsia can be mild or severe. In the mild pre-eclampsia, proteinuria may not be there. But in the severe pre-eclampsia only, proteinuria will be there and the end-organ problems are. And eclampsia, if you don't identify the case in the gestational hypertension or pre-eclampsia, patient can prove it, then it can go for the eclampsia. Then the chronic hypertension, hypertensive patient becoming pregnant. Pregnant patient where the BP is increased, we consider as gestational hypertension and pre-eclampsia. Hypertensive patient becoming pregnant is chronic hypertension. This is before 20 weeks. This is before 20 weeks, and these and all after 20 weeks to 40 weeks, and it may last up to the 6 weeks. With the single reading, we will not consider them as HDP. With the 2 readings only, we will consider it as the hypertensive disorder, which is taken apart 6 hours. So these are all the FOXY definitions. Excuse me. As I told, gestational hypertension, BP more than 140/90, more than 20 weeks. 2 readings and normalized after the 6 weeks postpartum. Chronic hypertension, known case of hypertension. Pre-eclampsia with the end organ and the significant proteinuria. This pre-eclampsia may be severe or non-severe. Non-severe lab parameters may be normal and no proteinuria. In severe, lab parameter may be abnormal and BP may be 160/110. More than that, and the symptoms. Always we will ask headache, blurring of vision, upper epigastric pain, and reduced urinary output and the movement of the baby. So next week, these are all the premonitory symptoms and the abnormal lab findings being low platelets, elevated liver enzymes, elevated serum creatinine, and abnormal coagulation. This depends on the degree of the HDP. So this preeclampsia is again divided into early onset and late onset. Early onset being less than 34 weeks, late onset being more than 34 weeks. Eclampsia is with the seizure superimposed, it can be associated with anything. So depending on the maternal mortality, hypertensive disorder complicates 8 to 10% of all pregnancies, and preeclampsia alone complicates 3 to 9% of all pregnancies in developed countries for the maternal mortality. Now we go with the case discussion. 24 weeks primary with BP of 150 by 100 comes to the OP with no other complications. So she has been with the regular antenatal checkup with you, but every month you are seeing the BP. At 24 weeks, her BP is no edema, nothing. Suddenly it is 150 by 100. And you are asking her to take rest for half an hour or 45 minutes. And again, the BP is 150 by 100. So we will start with Dr. Manjusha. Dr. Manjusha, how will you proceed with this case?
Good evening, ma'am.
Yes.
First, we will advise investigations to the patient. We will go for the urine albumin and other lab parameters, liver function test, kidney function test, serum creatinine, serum uric acid, and we will also ask for the ultrasonography to Doppler studies for the uterine blood flow. And then if the patient is not having proteinuria or other lab parameters are normal, then we label the patient as a case of gestational hypertension. And but if the lab parameters like there is proteinuria or other signs of maternal organ dysfunction, then we label the case it as a case of preeclampsia.
Yes, madam. So as she was telling, the basic investigation has to be done. Once the BP is increased means liver function test, renal function test, coagulation profile. You can also do the retinal exam. Fundus examination also can be done, because in future, if any complications happens means we can have that the base reading was normal. In as the big pregnancy progressed, there was the complication. So we would like to start with the labetalol. Dr. Shobha,
we will start with the medical management. We will start with the labetalol in the dose of 100 to 200 milligram 3 times a day, and then monitor the BP accordingly. And then we can increase the dose if the patient does not progress.
So Dr. Manjusha is going to start with the labetalol 100 or 200 or 300 depending on the BP. Dr. Shobha, would you like to accept the same, or do you want to start with other antihypertensive tablets? Dr. Shobha?
Yes, ma'am. We can start with either nifedipine 10 milligram PD or Nicardia tablets.
No, first you want to go with labetalol, or you want to go with the nifedipine?
We want to go with labetalol first.
So to better, universally, the labetalol is the drug for gestational hypertension and all the time. So if it is not, as Manjusha madam was telling, it can be given up to 300 milligram. If it is not controlling, you can add the other tablet of nifedipine, which is the calcium channel blockers. Dr. Jeevita, are you there? Would you like to tell about the other antihypertensive tablets which is available? So she is not there, I think. Dr. Shailaja, madam, what do you tell about the alpha-methyl dopa? Are you using alpha-methyl dopa in your place?
No. Olden days we used to use, madam. It is not available now easily.
Yes, madam.
So we are not using, but we are using only labetalol and nifedipine, and even IV also we are using labetalol.
Yes. So depending on the BP.
I just wanted to add here.
Yes,
now the tablet hydralazine is also available. Tablet in some places hydralazine is available, and it is a vascular smooth muscle relaxant, and it is coming up also, and there are some studies for hydralazine also, but labetalol is always a first line of drug what we use. Of course, at the periphery where the labetalol is not available, the people, even nifedipine is very popular. But we have to tell them that nifedipine should not never be given sublingually.
Sublingual.
And they have to take orally. And there are slow release, as you have put in the slide, that there are slow release preparations which are available. Now about alpha methyl dopa, it takes long time to act. And usually it causes some postpartum depression, so we don't use. And it was available earlier, and it was very popular drug, and it was a drug of choice when other drugs were not available.
Thank you, Dr. Vidya.
Hydrochlorothiazide, again, it is a diuretic, and we don't want to use that. Only in the emergency, sometimes it is used.
So, as all of us told, it is only the labetalol and nifedipine, hydrolysine tablet, as Madam was telling, it is available in some places.
Madam, sometimes nifedipine, excuse me, sometimes nifedipine used as a tocolytics for at least postpone for 24 hours before giving the steroids.
Yes,
For
madam.
preterm induction.
The only complication with nifedipine is sudden hypotension. If you are going to refer the patient to the higher institute, means immediately BP will reduce. And after going to that place, again, it may get increased. So as a conclusion, labetalol is the drug. Depending on the BP, we go with the nifedipine. This is a simple case of gestational hypertension. Now we will come to the second case. Gravida 2 P1L1 with 32 weeks gestation. Patient is already on antihypertensive, and that is from 28 weeks, since 4 weeks. Now the patient comes to the OP with the complaints of headache and blurring of vision. As normally we are asking, headache not relieved by taking analgesic, and blurring of vision is present. On examination, the per abdomen corresponds to the gestational age of 32 weeks, and BP being 170 by 110. Dr. Jasmina, are you there? How are you going to proceed with this case? If not that, Dr. Manjusha, again, you can take over the case.
Okay, ma'am. Since patient is already taking antihypertensive and is not getting controlled with it, so we will start with prophylactic magnesium sulfate in this patient.
Yes. How will you, what is the loading dose? Can you explain for the audience?
Ma'am, according to Pritchard's we can give the Pritchard's regime. Then in this, we give the total dose of 14 gram to the patient, and the loading dose is 4 gram IV 20%, which is given over 5 to 10 minutes time. And then we give the IM dose, which is 10 milligram. In this, we give 5 gram to the alternate buttock at the same time.
Yes. Manjusha, madam, in your place, are you following this Pritchard?
Ma'am, we are following only the Pritchard regime over there. We are not following the Zoo-Spans regime there.
Shailaja, madam?
Only where Pritchard's regime.
We are using Juspan also.
Juspan also. That is in the
Yes,
testing
so
in this
because
period.
it is IM infusion, they are painful. And even sometimes abscess is forming with that. So IV concentrated infusion we are using some patient.
So
1 gram per hour.
if you are able to monitor, as I told, 1 gram per hour, you can use the Suspan regimen. Since it is a case of increased BP with the
we should control her labetalol. Immediately with labetalol injection, and next send the pH profile. Then we should plan for delivery.
Yes. So you do the investigation. Labetalol control the BP. If the BP is not controlling it oral, you go for IV. That already you have told. So this is the Pritchard regimen, as all of us know, 20%. So each ampule is 1 gram. So you take the 4 ampules. Each ampule is 2 ml. In 20 ml syringe, you take 8 ml, mix with 12 ml of distilled water, make it as 20% and give IV. Then IM is 50%, 5 ampules in each upper and quadrant of right side and left side, 10 ml. If at all needed, you can mix with 1% of magnesium. So once the magnesium sulfate is given and labetalol is given, BP is controlled, means, Dr. Shobha, what do you want to do? Will you want to terminate or you want to wait for some more weeks?
She is 32 weeks, ma'am.
Yes, she is 32 weeks.
We can give her a betamethasone injection and wait for 48 hours. Then we can plan the termination.
Yes. So for the effect of the lung maturity, you can give the steroids. And this picture, all of you will be very aware of this maintenance dose, 5 gram magnesium sulfate 4th hourly, every 24 hours. And then depending on the Bishop score, next to Dr. Shailaja, would you go for a normal delivery or would you like to induce? And how will you proceed with this case?
Madam, depends on the Bishop score, depends on the severity of the pre-eclampsia. If patient is prone for eclampsia, better to go for a termination as a one of the option is best option is cesarean section.
What is the best option you told, madam?
No, if it is severe pre-eclampsia, patient is can throw means is a possibility.
Now she is having 170, 100 headache and blurring of vision. Now we have
Better
controlled
to go for termination early.
magnesium sulfate we have given to prevent the symptoms. Would you like to go for cesarean section or normal delivery? Our expert, Dr. Vidya Topi, what will you do for this case? Okay. So Shailaja madam wanted to terminate with the induction, madam.
Induction
Yeah,
Bishop
it
score
all
is better.
depends
Otherwise,
on the
better to go
Bishop
for a
score,
cesarean section.
the lie of the patient, and the obstetric conditions associated.
All normal Bishop score is 5.
Then I will induce.
With the monitoring.
So with the proper monitoring, you
Even
can
with
go for
poor Bishop score, they will take long time to deliver, ma'am. They
Time
may
will
go
it
for
is 5,
24
no?
hours.
Complications
And
can
in
occur.
between, they may go for HELP syndrome and thrombocytopenia.
No, we are monitoring, no? We are monitoring. We want to avoid unnecessary interventions. If it monitoring, we feel that she is deteriorating, definitely we are going to take.
Yes.
And
Then we
depends
can-
upon the FHS level, bradycardia or tachycardia, all these things we have to parameters we have to cover, then only we can plan. Otherwise, better if the cesarean
So the
section.
liquid it should be good and 24 hours monitoring should be there. And with everything, as Vidya madam told, you can go for induction, but careful monitoring is very, very important. The symptoms should not deteriorate and you should get the consent. At any time, patient can go for LSCS. So this is the way we are going to proceed. So in between that magnesium sulfate, we will monitor the respiratory rate, urinary output, patellar reflex. And if anything is present, we will skip the dose. And we are not going to stop the magnesium sulfate regimen. It will be continuing for 24 hours. So as she told, if needed, you can go with the suspend regimen also. The antidote for magnesium sulfate is calcium gluconate. We are not measuring the serum magnesium levels. With the history itself, we can monitor. Calcium gluconate is 1 gram, 10 ml of 10% solution. So this is the way we are going to monitor. So always when the patient is considered as increased BP after 20 weeks, ask these 4 questions: headache, blurring of vision, upper abdominal pain, urinary output, and finally fetal movement. As far as hypertension is concerned, we are bothered about the mother rather than the baby. If it is the GDM, we are bothered more about the baby because it will be the more than macrosomia. So these are all the normal pathology, proteinuria. This is the onset, early onset already. This we have discussed. This is prediction that dystosis score Meeta was talking about. This is the PREP collaborative network. For the sake of PGs, they may have this PREP collaborative network. What is that? What are all the things that have to be done? What are all the markers? For that, I have mentioned that. So always you should keep ready the PAH tray in the labor ward, in the antenatal ward, and in the theatre. Everything should be ready. At least 16 ampules of magnesium sulfate. It is the life-saving drug and it is the cheapest drug. So these are all the things which has to be mentioned. Then the third case, 28 weeks, Gravida 2, Para 1, Live 0 on antihypertension, and patient had fits at the home twice and now admitted with history BP of 200 by 110, and she is having the third fit at the hospital. Now again, we'll start with Dr. Manjusha. Dr. Manjusha, how are you going to proceed with this case?
Ma'am, in this we first do the journal management of the patient. We will first maintain the airway. Suction is to be done so that the patient should not aspirate. ABC should be maintained, airway, breathing, and circulation. Then we will take care that we will put mouth gag in the mouth so that there should not be tongue injury. And we should take care to prevent injury to the patient mother also. Then IV line is to be maintained and taking care that a large bore cannula to be fixed, so that as we have to take the blood samples also, and then we have to catheterize the patient. Oxygen is to be given, and then side by side we will ask our assistant, we will call for the help, we will
Yes.
shout for the help,
Always.
and we will call our assistant to take the quick history from the attendant or the husband of the patient. And at the same time, we will ask the sister to prepare the MAC sulfate solution, and we will start with the MAC sulfate.
Shailaja madam, would you want to add anything? Her BP is 200 by 110.
And if we can give injection labetalol to the patient to control the BP.
So always control the
Maybe
BP,
labetalol.
control
Injection
the
labetalol.
hypertension. Yes, control the hypertension. As she told, ABCD, if the tongue is better, means tongue will go inside and aspiration. So IV line, take the investigations and give the magnesium sulfate and the IV labetalol. Since the patient is unconscious, she is throwing fits, it is better to go with the labetalol, 20 milligram IV bolus, and after 15 minutes, repeat the BP. If the BP has reduced, it's okay. If it is not reduced, double the dose, 40 milligrams, and again see the BP after 15 minutes. Like that, you double it till to 20 milligrams. Once the BP is controlled, that is 140 by 90, like that means you can have the rice tube and have the labetalol tablets through the rice tube also. So IV labetalol can be given in this type of cases, labetalol and the magnesium sulfate. Simultaneously, you will give. Then how will you proceed with this case, Shailaja madam? Will you like to deliver or will you like to wait?
BP not under control means better to terminate irrespective of the gestation.
BP is under control. With the IV 80 milligram, BP is
And
now
other
140 by
parameters
90.
of the patient also we have to see whether the oligohydramia,
has thrown
IUGR,
thrice.
He has already thrown
Thrown
3
the-
episodes of convulsions,
conversation is
ma'am.
ideal.
Yes, madam.
So we should
Yes.
plan her for delivery only, because
So delivery, which is the mode of delivery you will prefer?
within 6 hours we should plan the delivery.
And induction we have to do because we
But
don't know the
if they are willing for good NICU stay, then we can do cesarean section, keep the baby.
Madam, for the such as cases, are you going for induction in your place?
No, we are bishops for food means directly.
Now she is only 28 weeks. 28 weeks. It's if you don't have a good NICU set, this 28 weeks of baby, it will be very difficult, no?
Our NICU is quite a little okay, ma'am. They are
even
managing
900,
with
they are
1
managing
kg.
with the good NICU, 900 grams also patients with the 30 weeks, 32 weeks also.
So you have to wait for 6
She is
hours.
little zero also, madam. She has lost her first baby also.
Yes.
She doesn't have any live baby now.
Yes, L0. That's the reason
Counseling is
I'm
very,
asking.
madam,
Will you go for
counseling is very
induction or-
important.
What, madam?
Counseling of the patient, survival of the baby, and recovering of the mother, all these things we have to counsel with the patient, patient attenders, then we have to proceed.
Patient attender is telling whatever you want, you do, madam. We want the mother.
Then you have to terminate the pregnancy as early as possible.
Termination is okay, madam. What is the method of termination?
Cesarean is ideally better
Yes.
to me because the induction will take a lot of time.
Yes, madam. Dr. Vidya, we want
Yeah,
to
I also agree with Dr. Shailaja, but lot of counseling for these peri-viable infants. Means they have got all neurological, all those problems. Even though your NICU facility is very good, we don't know the consequences for these very, very preterm babies. So that counseling you do, and you do your best, because termination of pregnancy is the answer for any eclampsia patient. So termination by cesarean section in this patient, because already she has thrown 3 convulsions and her BP is 200 by 120 or something. So we cannot wait for the induction to occur here.
Yes. So in such a case which is having 3 fits and everything is stable, means better to go for LSES to save the mother. And since she was not having the live baby, you should have a good NICU set or refer the baby to the good NICU set where it is available. Okay, the 6 hours waiting for normal delivery in our place we are not doing. I don't know that Dr. Shailaja's assistant was telling that she will be waiting for 6 hours, seeing the progress, whether she is deteriorating or normal. In that cases, you can go. So now we will go to the next case. She is 32 weeks primary. Madhumita, do you want to continue?
Ma'am, நீங்க பண்ணுங்க ma'am. I'll just I'm here only.
Yes.
பண்ணுங்க.
No, Madhumita was traveling, I saw.
Yes, 32
ma'am, I'm
weeks
here only,
priming
but it's-
on labetalol and nifedipine. And she comes to hope our labor antenatal OP with a history of abdominal pain. Always, if an antenatal patient with the labetalol and nifedipine comes with the abdominal pain, what will you first think, Dr. Manjuja? For all cases, we are
Ma'am,
starting with Manjuja.
this seems to be a case of abruptio placenta since she is hypertensive and she is complaining of severe abdominal pain and has tense and tender abdomen.
Yes.
I will first think of the abruptio placenta and I will investigate accordingly. First, do the PA to
Abdomen is tense and tender.
yes, and then I will go for the investigations. We will do the routine laboratory investigations, then followed by the USG to confirm the diagnosis.
So in these cases, since it is hypertensive patient can go for abruption and we may lose the baby. In that cases, we can go for LSS. Any one of you want to differ? Dr. Shailaja, Dr. Vidya, and Dr. Shobha?
Yes.
It means already you have to confirm whether baby is alive or no. Then you have to.
Finally, she delivered the stillbirth.
Stillbirth means better to induce and you have to control the hypertension.
See, now she's abdomen is tense and tender. What is the mode of
Abruption,
madam? It is a
Abruption,
case of
but
abruption.
it depends upon the cervical condition, whether it is dilated or whether patient is already effacement is good, then you have to induce and you have to
Yes.
arrange the blood and other things.
So if
Sometimes
she more than
these
4
patients.
days,
Depends on the coagulation profile of the patient also. No, we have to wait.
yes, if it is a dilatation,
Sometimes
it
these
means
patients,
abdomen would not be tense and tender. It would have come out. So it is Bishop score is less than 3 for this patient. So in this type of cases, even if it is
Hypoquite.
stillbirth, it
We
is
have to do
better to
cesarean
go with
immediately.
LSA. Dr. Vidya, do you want to tell anything?
No, I all 100% agree with the all panelists.
Because
as
we
well
may
as
lose
yourself.
the patient with the coagulation profile.
Yeah.
The result has to come.
Deranged coagulation profile, we will definitely lose the patient.
Then she may go for DIC. So it is better to terminate where even it is a preterm. So these are all the complications: abruption, visual disturbances, intracranial bleeding, other complications, and the pulmonary edema, oliguria. Baby, for that always we go with the growth restrictions. So in the next, always when you discharge the patient, you will counsel that in the next pregnancy, 30% can go for hypertensive disorder complicating pregnancy. Now this is another case, 34 weeks primary with a abdominal pain. Patient is on labetalol alone, 100 milligram BD since 20 weeks. Now she is 34 weeks. Per abdomen, everything is normal. So how will you proceed with this? Antenatal patients on antihypertensive, complaints of upper abdominal pain, what will you think? Dr. Manjusha?
I think Pranav
Seems to
Pranay
be
wants
a
to say
case
something.
of HELP syndrome because patient is on antihypertensive drugs and is complaining of upper abdominal pain. So it points towards the HELP syndrome. So we have to first do the laboratory parameters.
Yes.
Of this liver function test, platelet count, and this peripheral blood smear to see the hemolysis. And if bilirubin is more than 1.2 and as part ALT and AST are raised and has a low platelet count, then we will think of the HELP syndrome in this patient.
Yes, normally the hypertensive patient complains of upper abdominal pain. You should not tell take some antacids, take some gelusil. Always think of HELP syndrome. It can be the liver capsule rupture. So the same treatment is same blood transfusion, and you are going to control the BP and magnesium sulfate and then terminate. So Vidya, what is the mode of termination for this patient? Are you going to wait or are you going to?
I will not wait in such patients. I will definitely deliver her according to her, whatever the status as we have to assess her and deliver her.
Yes.
Another thing is all patients of severe preeclampsia, we have to screen. I think I should not use the word of screening for HELP syndrome, but at least peripheral smear, and if you do the LDH levels, definitely partial HELP and low platelets. Many patients we
Platelets.
get low platelets.
Yes,
in these
it,
patients.
basically we have to do that. LDH and all because BP increase means RFT, LFT,
Yes, yes.
coagulation profile,
All
everything.
profile, pH
And
profile. If you do,
so we
many
can be
patients
safe.
will.
Yes. So the health syndrome. So this is the way we are going to read. And when will you deliver? Automatically, this is normally health syndrome, severe preeclampsia, chronic hypertension. If they are severe means we are going to deliver them immediately.
Doppler issue.
And in case of a preterm pregnancy only, 1 minute. So in case of preterm pregnancy only, expected management, that too only for the steroid effect. Other than that, nothing. If the gestation age is less than 24 weeks, immediate delivery, we are not bothered about the baby. Only thing is between 28 to 33 weeks, the good NICU and monitoring is important. The mode of delivery, as everyone told, depending on the Bishop score and the urgency of the patient. Fluid restriction is better. Now, this is the last case, I think. Primipara delivered 2 weeks back. Patient was on antihypertensive treatment and she was discharged with levetiracetam. Now, patient comes with the history of headache. And her BP monitoring is 160/100. MRI is done. It is like this. Normally, nowadays, we don't know. Post-reversible in posterior reversible encephalopathy syndrome. This case, how are you going to monitor? Dr. Manjusha, we'll start with Manjusha and end with Vidya.
Ma'am, we will shift the patient to the HDU, such type of the patient to be shifted to the HDU. And we have to control her blood pressure.
Yes.
And if she is having seizures, we have to give MAC sulfate.
Yes.
Phenytoin we can give to such patients to control the seizures. And then supplement therapy. If she is having renal failure, we have to take care of that.
So again, for this patient, you control the BP with the antihypertensive and control the better to go with the magnesium sulfate. In the antenatal period, she didn't receive the magnesium sulfate. Suppose if the patient has received magnesium sulfate before delivery, what will you do for this patient? Now it is 2 weeks.
We can go for a levocetram tablets, levocetram.
Levocetram.
We are using
Levocetram.
So levocetram. Are you? Do you have any experience of giving the magnesium sulfate second time?
even first one dose we can give, ma'am, loading dose even in when they come.
But better to get it on serum magnesium level, madam.
Yes, there are studies which says that since it has been given 2 weeks back, for this patient it is not given. I am telling. If it is the gap of 2 weeks means after measuring the serum investigation, if the patient is having complications, you can give the magnesium sulfate second time. Normally, in my experience, I have never given, but for theory's sake, I am telling. This patient, since she didn't receive magnesium sulfate earlier, in this case, since fits under BP control, we are giving the magnesium sulfate. Whatever it is, BP control, seizure control, stabilize the patient. This practice, nothing.
In our institution, we are using levocetram.
Levocetram we are
yes,
using.
Shailaja, madam. Levocetram can be used, definitely.
1 gram as the
can you
loading
tell?
dose. 1 gram as the loading dose, ma'am.
Then how will you proceed?
Then 500 milligram BD for next 1 week.
Yes.
Then tablet form we can.
Then first you go with the injection, then you go with the tablet, and levocetram is nowadays used in many places. This prediction, no test can predict pre-eclampsia, and these are the first trimesters. These are all risk factors already in the gestosis code. She has told always this guidelines, but 162 milligram we are not giving. We are giving only the 150 milligram after the heartbeat, preferably 14 weeks. So the estimation of PLGF, SFLT by PAGF ratio, that is not routine, but it's the ratio if you consider if whether it is less than 38 or 38 to 85 or more than 85. With that, we can consider the prediction, whether she will go for the complications or whether she will be good. So this ratio, if it is less than 38 means you can be. If it is, it has to be delivered within 1 minute. Here I have that. So this is the value which has to be decided. This PIERS model, that is pre-eclampsia integrated estimated of risk. These are all for the PGs. In the recent advance, they may have the short notes. With this, we can maximum, you can wait up to 48 hours. What is the gestation age, chest pain, dyspnea, oxygen saturation, platelet count, serum creatine. Always this SFLT by PAGF ratio is the important thing which can predict whether it is less than 38 or 38 to 85 or more than 85. So if the PAGF value alone is not important, only the ratio will be useful. The Pelican study tells about the plasma placental growth factor. So nowadays, one of our PG is doing this dissertation. This Gestosis score, this is followed in Foxy. Already you had the wonderful talk by the Gestosis score. So whatever the prediction and prevention you had, that the calcium or whatever we are giving, that can be continued. So as a conclusion, monitor the BP properly, follow up the case, control the hypertension, prevent the complications, stabilize and refer. Whenever you want to refer the patient, stabilize the patient and refer. So this is the complications which we can we discuss. And I want one take-home message from all my panelists, wonderful panelists, Dr. Manjusha, Dr. Ashish. R.C. Sharma sir has joined us. Manjusha, one take-home message for the delegates, all panelists. We'll start from Manjusha. Manjusha, you are muted. Yes, madam, you can.
Madam, first identify early and monitor properly. Then next management in an early stage, as well as refer to higher center where facilities are there for the complications to handle.
Yes, madam. That is the best thing. Then Dr. Manjusha.
Yes, ma'am.
Madam told identify it earlier and refer early. That is best. If you don't have facility, refer it. That's all.
Ma'am, we have to identify the risk factors. And if the patient is having risk factors, we have to start. We can start with the aspirin.
That is for next pregnancy. Now, when will you start aspirin? Now, if it is 28 weeks means, when will you start aspirin? Normally, when are you going to start the echo?
Ma'am, from 12 to
yes, better. 12 to once the heartbeat has reached, we can start. For Apla and all, before itself, we are starting. That's different. In this case, after the heartbeat. Dr. Vidya, we want your...
Don't hesitate to give magnesium sulfate.
Yes, that is the thing.
Because many times at periphery, they are very much afraid to give magnesium sulfate. So we have to teach them how to give, how to monitor the patients on magnesium sulfate.
Yes. Dr.
Antihypertensives also, I want to tell that they are telling nowadays to start antihypertensive at 130, 140, 90 only. That's not at the 150, 100. So there are many studies, they are telling to start at 140, 90. Yeah. So we have to tell them to, yeah.
Thank you, Vidya. Sharma sir, do you want to tell anything? Sharma sir has joined. Yes, sir, you have to unmute.
Oh.
Welcome, sir. Sir, you are muted.
Sir, you have to unmute. Sir, please unmute, sir.
आप ना वो खोल के तो रख दो नीचे लिफाफा, मेरी मीटिंग चल रही है.
आपने अनम्यूट नहीं किया सर वो.
खोल के अंदर रख दो, कोई बात नहीं डालूंगी.
साइटी you do for sir, no? साइटी.
साइड पे गमले के.
Yes, sir.
Done it, madam.
Yes,
Done it,
हाँ, ठीक है, ठीक है. Okay, okay.
Yes, sir.
So this is very helpful, madam. The discussions which are all gone for this pregnancy hypertension and their treatment and how to save the mother and the child and when to intervene and so that it is beneficial for both mother and child. And really it is a very good this food for today's for a brain, which you have given. All the participants have participated very nicely, and this is a really helpful thing. So when to intervene, when not to intervene, so that is helpful for a baby and a mother both. So that if we consider only a baby and then we result with the death of a mother, this becomes a very bad. So we have to consider both the things and take a decision accordingly. So very good discussion, ma'am. Thank you.
Thank you, sir. R.P. Sharma sir is the president of Jammu Society.
Yeah, madam.
Yes,
thank
sir.
you.
Ma'am, there's a question in the chat box, ma'am. What drug would you prefer in the post-op, that is post-op or post-delivery time? What will you prefer?
I think it is postpartum hypertension, I
Yes.
think, or post-op. What
I
is
think they would have meant postpartum, ma'am. So what drug?
Postpartum, whether antenatal or postpartum or postnatal, whatever it is, depending on the BP, labetalol and nifedipine. That is, if the BP is severe, we go with labetalol injection. If it is patient is stable and BP is with 160-100 means oral labetalol and nifedipine if needed. Whatever may be the partum.
I want to add here one more thing is we should follow these patients long term also. These are the future, there is a future risk of cardiovascular diseases in these patients.
Yes.
So 1 year follow-up, 2 year follow-up, and these patients should be screened also for cardiovascular.
Definitely.
I may add one thing, madam.
Yes, sir. Pranay, sir.
So the postpartum, if the antihypertensive to continue for 10 days, and if it continues, then it is again patient has gone into essential hypertension. So for 10 days, we have to give antihypertensive, and if it goes beyond, then the same treatment of hypertension. Is it so?
Up to 6 weeks, we are going to follow, sir. If it continues more than 6 weeks, means we will make it as a chronic hypertension.
After 6 weeks or 10 days?
After
10
6
days
weeks. Only,
postpartum. Okay,
Madam, if I may, ma'am.
Yes, sir. Yes,
There
sir.
are certain points I want to tell, ma'am. Almost everything has been covered, and it was nice to visit all those days. But certain things, ma'am, like induction in case of PIH or severe PIH. Madam, even with unfavorable cervix, I have found that once you give this cervix prime gel, delivery occurs very rapidly in 4 to 6 hours. So just to say that we will not try because it's unfavorable. No, you try within 4 hours. If you are not getting result, you do this. Yes.
Yes.
Next point, we are using labetalol drip also, madam. It's not only labetalol 20, 40, 80. You give 20 bolus and continue with the drip 2 milligram per minute you give.
Yes, infusion with the drops adjustment you can give. We are also giving, sir.
Third thing, madam, in postpartum, if already we have given Maxelf and again patient throws fit, I have again given Maxelf, again controlled till patient was shifted to levacetam.
Within how many hours duration, sir? Is it 1 week or within 48 hours? If the
Madam, no duration. If you are a gynecologist, we are confident with the Maxelf. You start the Maxelf drip. You start 1 gram per hour, and the patient stabilizes. Then patient once stabilizes, then you get the MRI done, get the document press, call the neurosurgeon, levacetam is started, and hand it over. Now coming after delivery, which drug to be used? Nifedipine or labetalol? No, ma'am. Use telmisartan, Telma-H. Telma-H is very effective drug. It is very severe, then of course you would be giving IV drugs, IV labetalol, nicardipine or anything. But otherwise, along with it, you give Telma-H, and within 12 to 24 hours, it stabilizes, and that risk of that we are saying anything may happen to kidneys or babies, anything. This is all taken care of as the patient is in ICU. Because it is a team effort. It is not only gynecologist.
We are not using this telmisartan immediately, sir. At least for 2 weeks, where we are going with labetalol and nifedipine. I think we can.
Amlodipine can be used. Amlodipine we are using.
So since it is delivered as a Gurnesh sir telling, we can proceed. And patient diagnosis. One of the question is after 16 weeks we have to start aspirin or not. If there is no point in start, we can start the aspirin after the heartbeat. That is after 14 weeks you can start. No harm in starting the aspirin. Thank you, Gurneet sir, for your wonderful points. 3 points it is taken. Then if there is no other questions and no point, we will thank you everyone for attending the conference. For formal, Dr. Madhumita will give the vote of
Madam, one question.
Yes,
one
sir,
question
Pranay, sir. Yes, sir.
Sardarji, how much this telmisartan to be used? With how much telmisartan this diuretic is to use in a patient?
Diuretic?
How much is the dose? You know, he was
telling about telmisartan H. That's why he was.
He's saying telmisartan.
Along
how
with
much it should be
chlorothiazide.
given?
Gurnesh sir, what is the dose he is asking, sir? Tell me certain. Can you tell the dose?
So 40 plus 12.5, I'm starting, sir.
Yeah.
40 plus 12.5, I'm starting. And then every 8 hourly, I'm monitoring. So 40, it becomes 1 BD or 1 TDS.
Okay. So maximum dose of telmisartan is 80 milligram.
Yes, sir. According to him, it is 80. 40 plus 12.5. BD means it will come to 80 milligram.
Okay, madam.
Any other questions? Okay. Yes. So, Madhumita, can we finish with vote of thanks?
Madhumita, I think she logged out.
No
No, ma'am.
problem.
No, ma'am. A net problem, ma'am. I just got
Okay,
Yes, ma'am.
I will do that, no problem.
Yes,
So
ma'am.
I thank all the delegates and the faculties. I thank the president and secretaries of Jammu Society, Dibrugarh Society, Badman Society, Shifar, and Gulbarga. And I thank Dr. Vidya Topi for accepting to be the chief guest and guest of honor, Dr. Pranay, Dr. Ashish Sharma, Dr. Singh. And I thank Dr. Meeta for the wonderful talk on justice care, justice score, and I thank the chairperson Shailaja and Dr. Usha and wonderful panel with expert Dr. Vidya Topi, co-moderator Madhumita, and panelists Dr. Manjusha, Dr. Shobha, Dr. Shailaja, Dr. Jasmina and Jivika. Anyway, and I thank the moderator MOC Madhumita who is helping. And we are conducting this Pinnacle series every month, second and fourth Thursday. Second Thursday, 4:30 to 6:30, we are doing obstetrics. And fourth Thursday, we are doing the gynec. One talk and one panel. I request all of you to join on all Thursdays.
Sampath, please send a link.
Sure. I have created a Pinnacle group.
You add us in that Pinnacle.
You add and I will send them. Thank you, sir. Thank you so much.
Thank you very much. Thank you.
Thank you, ma'am.
Thank you so much, ma'am. Thank you, ma'am.
Thank you.
Thank you, Shaila.
Thank you, madam. Thank
Thank
you.
you.
You spared your time.
Nice. It was good.
Mm.